Thank you, Dr. Liu. Good afternoon, everyone. So as mentioned, today's webinar is going to be on thalassemia diagnosis and update on management. And this will be presented by our clinical hematologist in Hospital Sultana Bahia, Alostar, Dr. Asmida binti Abdul Aziz. So I think thalassemia, as you all know, is the commonest blood disorder in Malaysia. And if you follow our Malaysian registry, we have a national registry for thalassemia. We have close to 9,000 thalassemia patients in 2022, of which 55% are transfusion dependent and another 45% are non-transfusion dependent thalassemia or NTDT. So in hospitals without resident hematologists, I think we need our medical colleagues and medical officers to help us to co-manage and to monitor these patients. And therefore, we need to have updates on this area from time to time. So I would like to give you a brief introduction for our speaker for today, which is Dr. Asmida. Dr. Asmida actually graduated from UKM in 2004. And she obtained her Master of Medicine, Internal Medicine in 2012 and completed her hematology training in 2018. So actually for the hematology training, she trained in Penang and then Hospital Ampang. And for the thalassemia module, she had the opportunity to go to Italy. So she was in the University of Turin under the supervision of Professor Antonio Piga, who is actually a world-renowned expert for thalassemia. So Dr. Asmida also serves in Hospital Sultana Bahia, which is the second highest, which has the second highest number of thalassemia in Malaysia. And Kedah State is also the third highest in terms of number of thalassemia. So it's only appropriate that actually today we actually selected Dr. Asmida to give this topic. So Dr. Asmida, without further ado, I'd like to invite you to deliver this lecture.
Thank you, Dr. Go, for kind introduction. And also I would like to say thank you to the Academic College of Physicians for invitation for me to present about thalassemia diagnosis and also update on management. So I'll just share my slides with you. So by the way, yesterday was actually World International Thalassemia Day. So during the World International Thalassemia Day, most of the main icon tower will be illuminated by red color. So we have the opportunity to illuminate our Menara Alustar as red color yesterday in conjunction to celebrate World Thalassemia International Day. So I'll go for the introduction. As mentioned by Dr. Go just now, thalassemia is actually a very common disease. So it is categorized by abnormal production and a reduction in the rate of former of normal alpha or beta globin subunit in hemoglobin. So it can be categorized as beta thalassemia, alpha thalassemia, delta gamma or delta beta, etc. But most common disease will be alpha and beta thalassemia, which are two major categories, and the occurrence of depends on the 2 or 3 genes respectively. So we go for epidemiology. So it's more common, very common in Malaysia. It's very high prevalence because we are in a tropical country. So according to data, about 4.5% of population in Malaysia is a carrier. And according to the Malaysian Thalassemia Registry Report 2020, we have about 8,767 patients, where Sabah has the most patients with 1,907 patients, followed by Selangor. And in Kedah, we have around 903 patients, consists of the whole Kedah. Malay has the highest number of patients, followed by Chinese, but Karazan Dusun in Sabah is the highest population for ethnic group as a population in Sabah. So let us learn about hemoglobin. So primary function of hemoglobin is to transport the oxygen from lung to tissue, binding and release the oxygen in the cooperative manner. So hemoglobin is a tetramer consisting of two subunit, alpha 1 and alpha 2, as well as beta unit, which beta 2 and beta 1. So these are similarly structured and it's bind together with the heme group consists of iron, and it is held within heterocyclic ring known as porphyrin. So beta thalassemia has three types, mainly beta thalassemia major, beta thalassemia intermediate, and also beta thalassemia minor. So in beta thalassemia minor, there will be a lack of beta protein, and it is not great enough to cause problem in normal functioning of the hemoglobin. People with the beta minor is only carries the genetic trait of the thalassemia and usually experience no health problem except for mild anemia. And sometimes the patient with beta thalassemia minor does not have any symptom at all, and they probably doesn't realize that they are beta carrier, minor or carrier. Unlike in beta thalassemia intermediate, the lack of beta protein is actually good enough to cause problem. So sometimes they can have symptoms and signs of thalassemia. They will present with with bone deformity, spleen enlargement, and also anemia, which sometimes requires them to have a transfusion involved to improve the quality of life, but not in order to survive. So in beta thalassemia major, there will be a complete lack of beta protein in the hemoglobin, causing a life-threatening. So this patient major needs a transfusion, unlike in intermediate. Even though intermediate needs transfusion, they can survive without transfusion. So they also, in beta thalassemia major, they also have a more severe form of iron overload. So let's go into the pathophysiology a little bit. Okay, when you have a patient with a thalassemia, they have a reduced beta chain synthesis. So what happens is when you have a reduction or absence of beta chain synthesis, there will be an excess of alpha chain synthesis and also delta chain. So what happens in excess of alpha chain synthesis is you will precipitate to have an excess of alpha chain. Excess of alpha chain will cause you to have problems in the bone marrow, whereby there will be ineffective erythropoiesis and also in blood causing a hemolysis. Ineffective erythropoiesis is actually a hallmark of beta thalassemia. So hemolysis and also ineffective erythropoiesis cause anemia, whereby patients need transfusion, and because of that, they will have other complications like extramedullary hematopoiesis. I will explain that later. So at the same time, when you have an underproduction of HbA, you will have anemia, but at the same time, you also will have an increase of HbF as a result of increased level of HbF in the body. So HbF, as we know, will increase the affinity of oxygen in the body, and they will increase the erythropoietin production, causing an increased proliferation of erythroid cells. So when this happens, they will have skeletal changes as well as expansion of the bone marrow. So you have anemia causing a tissue hypoxia, increase of erythropoietin causing an extramedullary hematopoiesis, and also expansion of bone marrow causing a skeletal deformity and also hepatosplenomegaly. So as a result of ineffective erythropoiesis, they will also increase the erythropoietin, causing a suppression of the hepcidin. So they will be, because of the suppression of hepcidin, they will also cause increase of the iron overload as a result of increased intestinal iron absorption. So you have patient with beta thalassemia, they will have anemia, as well as the result of anemia, they will also have an iron overload. As opposed to alpha thalassemia, they in alpha thalassemia, they have alpha globin chain reduction as well, or block a deletion of alpha globin chain. So normally in alpha globin chain, they have four genes in total, two inherited from each parents. So alpha thalassemia cause deletion, and the amount of alpha globin chain production is depend on how many genes is deleted. So you have two genes. That in chromosome 16, and deletion of mutation 1 or alpha globin in alleles cause a reduction in quantity of alpha globin. So one deletion or two deletions usually does not cause a lot of problems. There will be a reduction of HbA, which lowers the hemoglobin content, but there will be no significant excess of beta globin or delta globin. So as a result, your patient with single deletion or double deletion, two deletion, usually they will only have mild anemia with microcytic hypochromic anemia, and usually they are also an alpha thalassemia trait. However, in patients with 3 or more alpha globin deletion, they will have a significant alpha globin production, so causing a significant reduce of HbA and lowers the hemoglobin content in RBC. So some of these patients presented with moderate anemia with hypochromic microcytic anemia, and when we do an electrophoresis or protein chromatography, they will show a HbH presentation. So in all deletion of alpha globin alleles, usually patients presented in the fetus, as fetus relies on HbF to take oxygen from the maternal blood. So no alpha globin production, causing an excess of delta globin. So as we know, HB bars are high in oxygen affinity, and this prevents the oxygen release to the tissue. So the fetus will have a tissue hypoxia and major organ failure in the fetus. So fetus will die in the uterus as a result of hypoxia and also heart failure. So how to diagnose a thalassemia? So the diagnosis is based on three clinical things, which is clinical features, lab investigation, as well as family history. So let's go into the clinical features. So as we all know, thalassemia patient will have anemia. Sometimes they will have jaundice, and some patients will present as gallstone. In early childhood, especially in major thalassemia, child will have a failure to thrive, and also some bone abnormality. When you palpate the abdomen, there will be presence of hepatosplenomegaly, and they have these specific features, what we call chipmunk faces, which consists of large deformed skull, frontal and posterior bossing, prominent zygomatic bones, and depression of the nasal bridge. Sometimes they also have malocclusion due to overgrowth of maxilla. Other than that, they also can have other bone abnormalities whereby they can have an expansion of metacarpal and metatarsal bones, broad ribs, and also shortening of the long bones. Because of the bone abnormality, sometimes you can see they presented as fracture due to marrow expansion, growth retardation, leg ulcer, and screen Rawlinson. So when you go for blood investigation, the basic blood investigation that you should do is full blood count, because both alpha and beta thalassemia carriers usually has hypochromic microcytic parameters with or without anemia. So when you do FBC, you expect them to have anemia with low MCH, MCV, RBC, and sometimes you can have a high RDW. Reticulocytes usually raise, and when we do peripheral blood film, there will be presence of hypopalmic microcytic red cells with a variation of size and shape of the red cells and increased polychromatic cells. Sometimes you can also see abnormal red cells like a target cells, Heinz body, and also basophilic stippling. So you use hemoglobin analysis as a screening tool when you suspect your patient to have a thalassemia. So what you want to do is you want to identify normal and abnormal hemoglobin and to assess the quantity of the hemoglobin. So in hemoglobin analysis, we have to know that in normal adult, HbA is around 95 to 98%, whereas in HbA2 is about 2 to 3% and HbF is only about 0.8 to 2%. In thalassemia, especially in beta thalassemia, there will be a decrease of HbA1, normal or rate and normal raised HbA2 and also high HbF. And in certain hemoglobinopathies, whereby there's a structural beta or alpha abnormality, you can see the presence of abnormal HB like HBC, HBS, and also HBE. So hemoglobin analysis, we can use it in two different techniques, which is high performance liquid chromatography or capillary zone electrophoresis, which both of these tests is very sensitive and precise to quantify as well as qualitative analysis of the HB components in the RBC. So you have, I give some summary of the HB analysis. So when you have a patient with beta thalassemia major, usually they will have HB level is less than 5 grams per deciliter. So when you do a hemoglobin analysis for this beta thalassemia, they will have a very high HbF and usually around 90 to 100 and slightly increase of HbA2. However, in beta thalassemia intermedia, the hemoglobin level usually reaching around 7 to 10 grams per deciliter. And when you do a HB analysis, the HbF is raised, but the level is not as high as thalassemia major, which usually around 10 to 50%. And you have a significant HB analysis, a HbA2 of more than 4%. In HbH disease, which is actually a form of alpha thalassemia before deletion, the hemoglobin can be varies. They can present it as 2.6 or they can have a normal hemoglobin. When you do a HB analysis in HbH disease, the level of HbH can be variable. Sometimes it can be as low as 0.8 or as high as 40%. So there will be a presence of alpha variant as well because HbH usually can have an alpha variant like HbH constant spring. And the other another type of thalassemia that are quite common in Malaysia, what we call a HbE beta thalassemia. It has three potential presentation. So when you have a HbE beta thalassemia, they have a mild, moderate, and severe. So the severe form of HbE beta thalassemia, their HB and sometimes can be as low as beta thalassemia major. However, in moderate HbE beta thal, usually the HB can be around 6 to 7, and in mild, it can be normal, more than 9. When you do a HB analysis for HbE beta thalassemia, you will find the accessory HbE, additional HB, which is HbE, and usually can be high as 40 to 60%. And you also will have a HbF, high HbF, and also high HbA2. So how to confirm whether your patient have beta thalassemia or alpha thalassemia. So you will do a DNA analysis. So in a DNA analysis, what we usually look into is a mutation in the beta or in a beta chain abnormality, which using a PCR based method to try to find or try to see a common known mutation in beta or beta 0. Sometimes we also do a direct sequencing or array analysis to look into a more rare or unusual mutation. Whereas in alpha thalassemia, as I mentioned before, alpha thalassemia is usually related with deletions. So the technique will be a little bit different as compared to beta thalassemia. So you use a gap PCR to find the alpha globin deletions. And sometimes when it is very difficult or unknown mutation, MLPA analysis and sequencing is being used. So molecular or DNA analysis remains the definitive diagnosis tool for thalassemia. In the presence of normal or inconclusive HbA analysis, you have to send for the DNA analysis to diagnose for thalassemia. Okay, let's go for managing thalassemia. So I think everybody is scared when you find or you see a patient with thalassemia. So I'll try to simplify the management of thalassemia into 3 important keys, which is number 1, you have to manage the ineffective erythropoiesis. And usually in ineffective erythropoiesis, patient will come with anemia. And secondly, you have to manage the iron overload in patient thalassemia. And number 3, you have to manage the complication of thalassemia. Let's go through one by one. So you have patients with thalassemia having ineffective erythropoiesis and also hemolysis, so they have anemia. So because of this anemia, you want to improve the anemia or the hemoglobin. So what you have to do is you have to do a blood transfusion. But at the same time, as I mentioned before, there will be increase of the iron absorption due to the disease itself. So you have a patient with anemia, which requires blood transfusion. And from the blood transfusion as well, you have an increased iron loading. And because of that, the iron overload will cause more problems and causing organ failure. At the same time, when you have an increased erythropoietin, you will have a bone marrow expansion and also extramedullary hematopoiesis. So you have patients with skeletal abnormality causing a bone problem and extramedullary hematopoiesis causing an organ enlargement, which is hepatosplenomegaly. Sometimes this extramedullary hematopoiesis does not only happen in the liver and spleen, but it can also happen in the paraspinal involvement, or sometimes they will have presented as abnormal mass in the bone. So knowing this information, so you will know how to manage the ineffective erythropoiesis. The most common cause, the most problematic ineffective erythropoiesis will be anemia, because this will lead to increased erythropoiesis, skeletal change, and also extramedullary hematopoiesis. So how to improve IE is by blood transfusion. So when you transfuse, your patient will have a good growth development, good energy levels, and sufficient to suppress the intra and also extramedullary hematopoiesis. So what's the recommended hemoglobin level for patient with thalassemia major, or sometimes in the media, is around 9.5 to 10.5 gram per deciliter. It should be administered every 2 to 4 weeks to make sure that the pre-transfusion hemoglobin is at that level. However, when you have a patient with a significant extramedullary hematopoiesis, like they have a paraspinal involvement, they have some heart disease, or some of the patient does not achieve adequate suppression bone marrow at the level that targeted before. So you have to aim for higher pre-transfusion hemoglobin, which around 11 to 12 gram per deciliter. So what are the indication for transfusion? There are two criteria only, which is number one, hemoglobin criteria would be HB level less than 7 gram on 2 occasions, more than 2 weeks apart, but you have to exclude other contributing factor of anemia like infection, sepsis, or other thing. Or clinical criteria, which is patient has a significant symptom of anemia, patient have poor growth or failure to thrive, patient have a significant extramedullary hematopoiesis like enlarging liver or enlarging spleen, and they might have an excessive intramedullary hematopoiesis like fracture or facial changes. So all these patients, you need to start transfusing them in order for them to have a better quality of life. So when you want to transfuse, definitely you want to monitor, and also you want to see the complication of IE. So blood transfusions, complication is the main problem for thalassemia. So when you do a monitoring for a patient, so you have to check for the pre-transfusion hemoglobin, liver and also spleen size. Growth chart in children should be recorded, whether you want to record in the patient's book, or you have your own file for the patient to have recorded. Sometimes, if you're unable to achieve the optimal pre-transfusion, you need to consider other cause of anemia. Sometimes when you have a patient which had been transfused so many times, they will start to have some complications of transfusion like alloimmunization. So, or chronic infection that we unable to which cause unable to optimize the pre-transfusion hemoglobin. So any transfusion reaction should be recorded for a further report later on, and ideally all thalassemia patients need red cell phenotyping prior to transfusion. And when you want to transfuse them, I will suggest to use a phenotype blood for the patient. Okay, in managing iron overload, so we go already past the managing iron ineffective erythropoiesis. So now how to manage the iron overload in patient. So as I mentioned just now, iron overload is as a result of red cell transfusion and also increase of iron absorption in the GI. In TDT, transfusion dependent thalassemia, which is usually beta thalassemia major, the mechanism of iron overload is usually secondary to blood transfusion, whereas in non-transfusion dependent thalassemia, which is thalassemia intermedia or thalassemia minor, they will also have a high iron level or high ferritin level, but their mechanism is different from the patient with thalassemia, transfusion dependent thalassemia. So usually in NTDT patient, there will be a hepcidin suppression, and this enhance the increased intestinal absorption of the iron. So this will cause portal and subsequent hepatocyte iron overload, and relatively cause the lower serum ferritin compared to TDT patient. So iron will accumulate in the body, in the organ, causing toxic to many of the tissue, which lead to cell death and also organ failure. So how to prevent this to happen? So you have to start a chelation therapy, aims to balance the iron that they receive by increasing the excretion of the iron in the urine as well as the feces. So you have a patient, when you have a patient that have a very, very high iron saturation, so the plasma transporting binding iron will be too saturated, And this will increase the NTBI, non-transferrin bound iron, to be very, very high. So when this happens, there will be increased iron loading to certain organ. Usually it happens in the pituitary, parathyroid, heart, liver, pancreas, and gonads. And because of the suppression of the hepcidin, this will also cause increment of the iron, increment of the intestinal obstruction, causing more iron to be restored and keep in the body, and will cause more plasma transferrin binding iron. So what will happen is this labile iron, which is very excessive, will cause organ damage by increasing the oxidative stress to the cell and causing cell death and fibrosis in the liver, and sometimes with the anti-apoptotic abnormal genes, they will sometimes cause neoplasia in the body. So how to monitor iron overload? So the most valuable value to monitor iron overload is by doing a liver iron concentration. So last time when we don't have MRI T2 star, we do a liver biopsy to calculate or to measure the LIC value. And LIC value more than 5 milligram per gram dry weight has been shown to associated with a lot of morbidities. But nowadays, with a lot of good technique, so we can measure LIC by doing an MRI T2 star. Any increment of the LIC value is associated with increased risk of iron overload and also organ damage to the body. And if you have a sustained high LIC above 15 milligram per gram dry weight, it's usually linked with a worsening prognosis. So if you have a liver LIC more than 15 milligram, you can have a liver fibrosis, and thus later on it will cause cirrhosis. So how to monitor LIC? By how regular do you want to monitor LIC? By doing an MRI T2 star. If you have a level of stable like 3 to 7 milligram per gram dry weight, usually you can repeat the MRI T2 star 1 or 2 yearly. But if the level of LIC is more than 7 milligram per gram dry weight, try to do MRI T2 star yearly. However, if let's say the level rapidly increase more than 3 milligram per gram dry weight, you have to do it 6 to 12 monthly. So I'll just show you a schematic. When you have a patient with LIC normal less than 1.2, the risk of developing complications are lower. As you go towards the mild, moderate, and severe, you will see the color changes. So when you have a mild, the risk of developing complication will be milder as compared to when you have a LIC more than 15 milligram per deciliter. Other than that, you also can monitor your serum ferritin, and serum ferritin of more than 2,500 is considered a severe form of serum ferritin. And the other way is to do a T2 star of the cardiac, and you have to target more than 20 milliseconds as a normal value. Serum ferritin. Study shows a high serum ferritin associated with the control of the prognosis of the patient. So usually we have to monitor serum ferritin every 3 months, and target value is around 800 to 1,000 milligram per liter, measuring 800 to 1,000 milligram per liter. However, you need to see the trends in the serum ferritin rather than rely on the single reading as a target value for your patient. So there are three types of iron chelation agents that are available in Malaysia. So you have a deferoxyrox, which known as SJ, deferriprone, and also deferoxamine or desferal. So just write to you or show you the indication of all these three medications. So children of 2 to 6 years old, deferoxyrox and deferoxamine can be used as the first-line therapy. However, in deferriprone, there's no enough clinical data and licensing to allow we to start deferriprone. If let's say patients are more than 6 years old and or adult, you can use any of the iron chelation as the iron chelator. However, guidelines says that you can start with Desferra as your first line, or you can start your Deferra as a first line. If other chelator or Desferra is not tolerable or ineffective, you can start patient with deferriprone. The good thing about deferoxyrox and deferriprone is both are orals. Deferoxyrox has a film-coated tablet, whereas in deferriprone, it is a tablet or liquid forms. So patient would be preferred to take oral tablet rather than in Desferal or deferoxamine. Usually is given through the subcutaneous infusion or IV infusion. So patient needs to go back and inject themselves with a special needle as well as special machine to chelate the iron. So it's not a very famous or very interesting to do to inject themselves. So most of our patients prefers deferoxyrox and deferriprone as the first line therapy for iron chelation therapy. So starting dose for deferoxyrox will be 14 to 28 milligram per kilo per day, and it is a single dose, only daily dose. As compared to deferriprone, it's a 75 milligram to 100 milligram per kilo per day, and is given in 3 divided dose. You have to give 3 divided dose. As for Desferal, you can have a 20 to 60 milligram per kilo, and is given 5 to 7 times per week. And in children, we can go up to 40 milligram per kilo. Okay, contraindications in deferoxyrox would be pregnancy, hypersensitivity, patient with low EGFR, and also patient with hepatic and renal failure. In patient with deferriprone, contraindication for deferriprone would be pregnancy, hypersensitivity, history of neutropenia, and condition under the risk of cytopenia. This is very important because deferriprone can has a very problem with neutropenia. And in Desferra, you can use Desferra in pregnancy after the 3rd trimester. However, hypersensitivity is still a contraindication. So what are the side effects or of all these three iron chelation? Definitely, GI disturbance is the most problematic in for deferoxyrox and also deferriprone. Especially in deferriprone, a lot of patients will tell you that they have a lot of problems with GI. But the most important thing, I think the most problematic side effect in deferriprone would be neutropenia or agranulocytosis. Other than that, you can sometimes have an increased liver enzyme in deferriprone. In deferoxyrox, the GI disturbance is not so much with the current film-coated tablets. However, you have to be careful in terms of there will be a higher risk of increase in creatinine level with patient with deferoxyrox, and sometimes they will have proteinuria in their urine. So patient with deferoxyrox should be monitored for the kidneys as well as the urine every time they come for follow-up. As opposed to deferoxamine, They can have auditory and ophthalmic complications. So you have to send your patients to a yearly assessment by your ENT as well as your eye specialist. And then other thing that sometimes people might be forgetting is Desura has a higher risk to develop Yersinia infections, and we have few of our patients with a Yersinia infection previously. So when you have a patient already on medication, you have to monitor for the side effect, other side effect of the medication. So every time your patients with iron chelation, you have to do a fast full blood count. In deferoprone, you have to do it baseline, and sometimes you do have to do weekly for them to prevent agranulocytosis. In divarothirox, we have to do a serum creatinine monitoring, urinalysis, and urine protein creatinine ratio. All patients with iron chelation should be monitored liver function, and patients with divarothirox and also Despera should have a ophthalmic and also audiometry examination. So how do you want to start your medications? So if you have an ejection fraction, normal ejection fraction with a serum ferritin more than 4,000, so you have to start something. So your strategy, maybe you will start something like Deferoxirox or Despera high dose, or you can also do a double iron chelation, whether you combine Despera with Deferoxirox or you combine Despera with Deferoprone. But if you have a normal ejection fraction, with a serum ferritin around 1,500 to 400, you can actually use a single iron chelation, be it Deferoxirox or Desferal. Or if let's say you have a serum ferritin less than 1,500, you can use whether Deferoxirox, Deferoprone, or Desferal. However, when you have a not abnormal ejection fraction, you need to admit the patient, start the patient with 24-hour Desferal infusion, and you need to start with high-dose Deferoprone to patient. Managing other complications. So this is the last one. So in order for you to manage the other complication, you also have to know what other complication in thalassemia. So you have the one picture here. So you have a NTDT and also TEDT. So high iron overload in TDT usually associated with blood transfusion, whereby iron overload in NTDT usually happens because of the ineffective erythropoiesis, causing an increased intestinal obstruction. So patient might have a endocrine abnormality like pituitary dysfunction, hypoparathyroid, cardiac cirrhosis, liver cirrhosis, diabetes, hypogonadism, and also sometimes they have silent stroke, hypothyroidism, or pulmonary hypertension. So you also need to monitor the proteinuria. Patient can have a venous thrombosis or leg ulcer, and most of the time they can have a bone disease. So let's discuss about a little bit of cardiac complications. So you have a patient with hemoglobin defect, and usually this will cause hemolysis. So hemolysis causes anemia, and because of anemia, you need to transfuse the patient, and there will be high output state in the body. So high output state can cause a higher risk to develop pulmonary hypertension. And this also can cause a ventricular dysfunction. And patient with anemia in thalassemia, sometimes they can have a very severe pulmonary hypertension. They can also develop cardiac failure due to high output state, and they can also have arrhythmia due to ventricular dysfunction, as well as cardiac failure due to causing arrhythmia. Apart from that, they also can have a vascular defect, whereby this vascular defect cause thrombosis in the vessels, and this thrombosis can cause embolism, causing a pulmonary hypertension to patient. So how do you want to prevent this to happen? The treatment for cardiac complications in patient with thalassemia is to optimize the blood transfusion. Patient with cardiac complication require higher target pre-transfusion hemoglobin. At the same time, you also need to actively or aggressively chelate this patient, and it should be intensified, targeting around 1,000 in thalassemia dependent transfusion dependent thalassemia, or around 500 to 800 in non-transfusion dependent thalassemia. Some patients will develop arrhythmia. They may need a pacemaker, or if let's say your patient develop anti-failure, you might need to start patient with anti-failure therapy. How to monitor cardiac complication? There are 5 things that you need to do in assessing a cardiac complication in your thalassemia patient. Number 1, history examination, history taking. Every time you come and see the patient, every time your patient come and see you, you need to assess how is their cardiac or how is their heart function. So you can ask them how is their availability, their affordability, or their function to walk from how distance is the walking, and you can do a physical examination, do ECG, and also check for the echocardiography every year. The other thing is to do MRI to start of the cardiac for your patients, and you do MRI to start of cardiac and also liver at it simultaneously. So in liver complications, two major cause of liver disease in patient with thalassemia. Number 1, you have a patient with liver iron overload, and number 2 is viral hepatitis. And viral hepatitis usually as a result of frequent transfusion causing a viral chronic viral hepatitis like a hepatitis B and C to the patient. So when this happens, they will have a chronic inflammation of the hepatocyte, fibrosis, and later on develop cirrhosis. In recent years, with the good survival of the optimal thalassemia care, hepatic cellular carcinoma is actually one of the common cause of the liver disease in our patients. It is important to monitor and also assess each time of the visit for any sign and symptom of chronic liver disease, and we have to monitor liver enzymes and also ultrasound HbS if necessary. Treatment of the liver complication must be according to the etiology, and if let's say it is an iron overload, you have to optimize and aggressively try to bring down the serum ferritin and make sure that the LIC is less than 3. Some patients will have a growth failure. Despite with major therapeutic advances, a lot of our patients fail to grow. So the pathogenesis of the growth failure is multifactorial. A lot of the contributing factor is due to the chronic anemia, transfusion dependent iron overload, and also chelation toxicity. Apart from that, some of the patient has an endocrine problem, poor nutrition support, and emotional support that also contribute to the growth failure. I think the most important in making sure that your patient does not have this growth failure is to adequately transfuse your patient. Okay, endocrine complication, delayed puberty, hypogonadism, hypothyroidism, impaired glucose tolerance, or insulin-dependent diabetic mellitus and hypoparathyroidism. All these are actually endocrine complications. What I think the most important things about endocrine complication is periodically you need to do an endocrine assessment, and usually you have to carry out about 6 monthly in transfusion dependent thalassemia after they age 11 years old. What are the endocrine tests that you should set? Calcium, phosphate, your thyroid function test, your sexual test, and also you also need to send for bone marrow density to your patient. So I'll go with the update of drug therapy in thalassemia, which kind of new in Malaysia, but not very new as in a worldwide. So a new novel drug therapy, as what we call luspatercept, is a recombinant fusion protein comprising a modifier extracellular domain of the human activin receptor type 2B fused to Fc domain of the human IgG. So what will happen is they will promote more late-stage erythroid maturation, causing more RBC or more FVC. So in the LEAF trial, phase 3 randomized, showed a very good response of a patient with transfusion-dependent thalassemia, where about 20% of patients receiving luspatercept experienced very good erythroid response within weeks 13 to 24 of treatment, which significantly higher proportion than patients receiving placebo. So you also, some of the patients, about 70 patients, experience about 33% reduction of transfusion burden over any of 12-week period in patient with luspatercept. So luspatercept increase your hemoglobin. So you have to, so your patient, they have a reduced transfusion burden. So it is one of the newer drugs that helps to reduce the transfusion burden and also back cell transfusion. So however, luspatercept actually not really work in patients, in certain patients. So the luspatercept group has top priority to certain patients, and you also need to assess whether luspatercept works to all these patients. So in group 1 top priority, patient that should receive or has a more potential in good response with luspatercept are patients that receive moderate transfusion regime. Patient is non-beta 0 beta 0 genotype. Patient is prenectomized patient, and patient that unable to sustain transfusion regime to the target, and also patient with progressive iron overload.
Asmida, you got a few minutes left, huh?
Oh, probably this is not that important, but in luspatercept treatment, you have to categorize your patient to group 1, group 2, or group 3. Patient with group 1 will receive or will respond quite well with luspatercept, as opposed to a patient in group 3, they will have a satisfactory response. So adverse effect is very minimal in luspatercept, and bone pain is usually the most problematic problem. So the other newer management or newer technique or newer treatment for thalassemia will be gene therapy, because you know curative therapy for thalassemia is allogeneic stem cell transplant. However, less than 25% of patients has a HLA match. So gene therapy is to aim to cure the genetic by replacing or correcting the defective gene in patient's DNA. So you have a patient, we harvest the stem cells, and then we edit the genes using some vector and also cytokines. Then we will do a conditioning to this patient, and we will insert back the stem cells into the body. So generally, this is the principle. Because we don't have much time, I'll just keep that. And further therapeutic in beta thalassemia will be mini hepcidin, mitapivat, and also apotransferrin administration. So I conclude my presentation. Welcome you any questions.
Okay, thank you very much, Dr. Asmida. That was a very extensive lecture. we have generated many questions in the question box, okay? So we start off with pregnancy. So one of the attendees would like to know, if a thalassemia patient wants to get pregnant, what will be your plan? How do you prepare the patient? And also they would like to ask regarding contraception, whether you do you continue iron chelators once the patient is already planning for conception? And also regarding the control of iron level during pregnancy and after pregnancy.
Okay. If you have a patient with transfusion dependent thalassemia or thalassemia major, usually I would say that first assess the how bad is the genotyping. Number two, I would assess the partner whether the partner has a risk to develop another major. Number two will be how optimize the patient, whether the hemoglobin is well controlled or not. Number two, I need to consider serum ferritin and also iron overload complications. If all these are normal or well controlled or optimized, I don't have any reason to not to let my patient get pregnant. So your question would be, so what is your normal level for your serum ferritin? I will keep your serum ferritin less than 1,000, the optimized serum ferritin before your patient allowed to go pregnant, and a normal MRI T2 start if possible, because during the pregnancy you might need to stop your iron chelation. So 9 months without iron chelation, but with regular transfusion, is very difficult to bring back your iron later on.
So the question was, do you ask the patient to stop chelation therapy? At which point do you ask them to stop during once they have decided on that they want to embark on pregnancy? Do you ask them to stop, or do you only stop after they have conceived?
Guideline says that you have to stop during the first trimester. So if let's say they plan for transfusion, plan for pregnancy, you need to stop immediately once they decide for pregnancy. So
Yeah.
that's my answer.
So the problem is sometimes you want to stop
Yeah.
before, but they don't get
They
pregnant,
didn't
right?
get
So end
pregnant
up
through.
too long without the iron chelation. So
Yes,
most
yes,
of us, I think, will stop once the patient get pregnant, right?
yes, true.
Okay, all right. So there are a few questions regarding side effects of iron chelators. So one is regarding the ophthalmic side effect. So one of the attendees asked whether it is reversible, and another one want to know what is any risk factor for developing ophthalmic side effect.
Uh, uh, y- the ophthalmic effect of the iron chelation is actually reversible. You stop your iron chelation, it will return back to normal.
So which
And
iron
actually,
chelator?
Desperal,
Okay.
Desperal. Deferoxyrox, so you don't have much complication. I rarely see Deferoxyrox with ophthalmic effect in my experience. And any particular risk factor for ophthalmic, not that I know of.
Is
I
it dose
don't,
related?
unless it's iron too high serum ferritin.
No. Is it dose related with regards to
Oh
your
yeah, yeah, it's
desperal
those related.
dose?
Yes, yes,
Yeah.
yes, those related.
So there's also some questions regarding the renal complication, right?
Yeah.
So let me see, where is scroll down. So they would like to know how you will taper exudate. So they know that exudate is one of the main concern is of course renal impairment. So let's say if the patient has renal impairment, how do you taper exudate based on EGFR? And also for severe AKI, do you actually stop your exudate? They want to know the guideline.
Uh, there's no guide in terms of that. Severe AKI we stop immediately. But there's also no guideline in terms of those related of GFR, meaning that if let's say your GFR is 40, you cut down to by half. There's no such thing as that. So once you notice that your GFR is already coming down trend, and also there's a presence of proteinuria, I would usually try to stop your SJ and try to replace it with other things.
Which would be the safest choice then
Yes, yes,
in
true.
terms of iron chelator?
Yes, true.
Which iron chelator do you think is the safest for a patient who has developed renal impairment? Is it diferriprone or is it desferal?
If you ask me, I will answer as
Yeah.
no,
Yeah,
deferral.
diferriprone. I think diferriprone is known to be the
Deferral.
safest in terms
Yes,
of renal impairment. Yeah.
yes, true.
Okay. So there's another question regarding cardiac iron overload. So the question is, which iron chelator is suitable for patients with cardiac iron overload?
Mm. Um, hmm. um, I would say deferral as well as deferral both are the similar effect of the to patient with a cardiac overload. Uh, unless patient with heart failure presented with acute heart failure and also very high iron overload, I will admit the patient, start with IV desferal infusion with high dose deferoprone. That is the guideline says. But if let's say you're talking about chronic cardiac iron overload, I think SJ has a good component to reduce the cardiac overload.
Would you consider combination therapy? For
Yes,
instance,
yes, definitely, definitely.
yeah. So I think L1 is L1 or diferriprone is considered as having the highest
Yes, yes,
cardioprotectivity
true.
effect. And there are quite a lot of papers in combination with desferal where the clearance of iron overload from the heart is actually faster. Yeah. But even then, I
That's
think
true.
cardiac endocrine, it will take several years to actually clear the iron, right,
That's
from the
true.
heart.
Yes.
Unlike liver, where you can actually clear in 6 months. Yeah, okay. So there's another question regarding stem cell transplant. So they would like to know what situation would you consider stem cell transplant? So what's your criteria basically?
That's the criteria for stem cell transplant. Um, we never do a stem cell transplant in adult, and usually stem cell transplant for thalassemia usually done in kids age, pediatric age. You have to have a very good iron loading. I mean iron control. You also have to have a very minimal blood transfusion, and also overall ECOGs are good, performance status are good. So
Yeah.
these are the three, and also matched siblings. I think these are the four items that you need to look into that, and we do it a lot in pediatric age rather than we never do in adult age.
Yeah. I think their cutoff is 16 years old, below
Yes.
16. But I think recently there was a paper presented by UMMC on our local experience. So they got quite a big data. So I think their median age for transplant is 5 years old.
Yeah,
Yeah, so usually less than 7 years old is preferred
that's true.
before the iron loading happens. Yeah. Do we have time for a few more questions, Dr. Liu? Maybe one more question?
Yep, can
Yeah,
one more.
so we are about 5 minutes past time. So let's see. Okay, this is a practical question, Dr. Asmita.
Yeah.
So for those patients who are quite heavily iron overloaded, so they would like to know how to infuse desferal infusion in the ward. Do you bring in your patient, those not very compliant, already ferritin 10,000, do you bring them in for IV infusion of desferal in the ward? And if you do, how do you do it?
Usually we patient with very high ferritin we bring in to start infusion 24-hour IV to them. You can start with dosing around 20 to 40 milligram per kilo, but if let's say it doesn't work, you can increase the dose to 60 milligram per kilo. We are very cautious on increasing to 60. I usually use around 20 to 40, then slowly taper up. The reason being is because I don't want to to bring down the labor iron too fast, sometimes they do have some arrhythmia going on because of the sudden drop of the iron in the body.
Okay, thank you very much. So I think we are a bit past time already. So I would like to thank everybody for their very interactive and active participation. I'd like to thank Dr. Asmida for her excellent lecture, and also College of Physicians for hosting this lecture and this series of webinar on hematology. So I think there are a few more questions. So if those of you that the questions are not answered, maybe you can leave your email, and then Dr. Asmida can actually email you for the answers. Is that okay, Dr. Liu?
Right, sure. Can.
Okay, then. Thank you very much, Dr. Liu.
Thank you, Dr. Go, Dr. Asminda.
Thank
Thank you,
you,
everyone. We'll see
everybody.
everyone next week.
Thank you so much.
Okay, bye-bye.
Bye.
Yes, we did. Finally.